Salah intro. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi, salam sejahtera untuk kita semua. Yang terhormat Dekan FKUI yang dalam hal ini akan diwakili oleh Profesor Dr. Diana Okvianti, spesialis Opjin, konsultan MPH, wakil dekan bidang pendidikan, peneliti dan kemahasiswaan. Yang terhormat Ketua Departemen Ilmu Kesehatan Anak, Dr. Fatima Safira Alata, spesialis anak konsultan PhD, Ketua Prodi S1 FKUI yang dalam hal ini akan diwakili oleh Dr. Dina Mutiarti, spesialis anak konsultan, and our dear guest speaker, Profesor Susan Sawyer, dan tentunya mahasiswa FKUI beserta modul elektif kesehatan remaja, serta seluruh peserta guest lecture pada pagi hari ini. Alhamdulillah kita semua bisa berkumpul pada pagi hari ini via daring ya dalam keadaan sehat. Dan sebelumnya perkenalkan saya Dr. Bernadise yang bertindak sebagai koordinator program modul elektif kesehatan remaja Departemen Ilmu Kesehatan Anak FKUI RSCM, sekaligus moderator untuk kegiatan kita pada hari ini. Sedikit saya minta izin untuk memberikan laporan untuk kegiatan hari ini, dan izinkan karena kita sudah hadir di sini Profesor Susan Sawyer, izinkan saya berbicara sedikit dalam bahasa Inggris supaya beliau bisa mengerti apa yang kita lakukan pada hari ini. As we already know that adolescent is the phase life between childhood and adulthood, ranges from 10 to 18 years in Indonesia, where rapid physical, cognitive, and psychological growth happen. And this stage plays a very unique and important role for foundation for good health in the future. And Child Health Department, Faculty of Medicine, University of Indonesia, has been continuously introducing and developing adolescent health, not only to medical students, pediatric residents, but also to larger societies. And we are very pleased here to present elective module for adolescent health to our beloved young and energetic medical students to give them more comprehensive and infinitive experience in dealing with adolescent health. Our program will involve not only clinical experience and learning in Cipto Mangunkusumo Hospital as our teaching hospital, but also in community experience as important role in adolescent health as well. Students will also involve not only in pediatric department, but also in other related departments like OBGYN, and then dermatovenerology and also psychiatry. And as for today's agenda, we are so proud to invite one of the global pioneer in adolescent health, Professor Susan Sawyer, to give an introduction, and it is open for everybody here. She will give the topic Understanding Global Adolescent Health. She is the chair of Adolescent Health in Department of Pediatrics and University of Melbourne, and a pediatrician by training, and she is also the director of Center for Adolescent Health, Australia's leading academic center of excellence in adolescent health, which is based at the Royal Children's Hospital and Murdoch Children Research Institute. Morning, Susan, Professor Sawyer. Morning. Okay, I will back talking in Indonesian. So selanjutnya adalah kita akan masuk pada sedikit sambutan dari Ketua Prodi S1 kita yang akan diwakili oleh Dr. Dina Muktiarti, spesialis anak konsultan. Pada Dr. Dina, kami persilakan.
Thank you, Dr. Bernie. I'm not sure, should I speak in Indonesian Bahasa? So, Assalamualaikum warahmatullahi wabarakatuh. Good morning, professors, seniors, colleagues, and my dear students. So, today we attend guest lecture from one of the leading person in adolescent health, Prof. Susan Sawyers. This guest lecture, as already Dr. Bernie mentioned, is a part of the elective module by Department of Child Health Faculty of Medicine, Universitas Indonesia, that led by Dr. Bernie. And we know that adolescent is recognized as a critical time for physical, mental, and behavior development. And it will create a foundation for this person as an adult. So I think this is one of the important phase of a child. So we have to learn more about adolescents and their problems. So students, get ready to have your experience in this unique module, I think. And as coordinator of education for undergraduate in Department of Child Health, I'm very grateful and proud that our students have this opportunity to learn more from Professor Susan Sawyers. Thank you so much, Professor Susan, and also Dr. Bernie and team. Hope we can learn a lot today and the rest for 4 weeks later until this module finish. I think that's all from me. Thank you, Dr. Bernie. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Dina. And then next, I would like to invite our head of Child Health Department, Dr. Safira Alatas. Over to you.
Thank you, Dr. Bernie. Good morning, everyone. Assalamualaikum warahmatullahi wabarakatuh. The respected the Dean of Faculty of Medicine, which is now Professor Dwiana Okvianti, Dr. Bernie, Dr. Dina, and Professor Susan Sawyer, and dear students. So I'm very happy, I think, that there's an elective model for our students, which is now want to learn more about adolescents. Because in Indonesia, I think adolescents' health is not yet well managed. I think, and Dr. Bernie is one of leading person in Indonesia who is very concerned about this adolescents' child health. Some of the child was managed by pediatrician and some with internal medicine. So it's not yet well managed with one division, or some pediatrician did not realize that this is very important, that for us it's a transition between children and adult, and it's very unique. This phase is there's some conflict of their psychological things and some diseases which is overlap between children and also adult. So I'm very happy today that this from now until 4 weeks, there's students who wants to know more about this adolescent health. I'm very happy. I'm very thankful for Professor Susan Sawyer, who wants to teach our students this coming 4 weeks. I hope they learn lots of things about adolescents' health, which is very important for them when they are graduate as a doctor. Thank you very much. I hope you enjoy teaching our students. Please come to Indonesia. Good morning. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Safira Alatas, for the introduction and also for the welcoming speech. And now I would like to invite the Dean of our Faculty of Medicine, but currently will be presented by Dr. Wiana Oktivianti, which is very familiar with Professor Susan Sawyer too. So Professor Okti, over to you.
Okay, thank you so much, Bernie. Good morning, everybody. Assalamualaikum warahmatullahi wabarakatuh. Especially to Professor Susan Sawyer. Nice to meet you again. So we have a long discussion before for our program with Dr. Bernie. And now, thank you so much for having you to give such a very interesting lecture about understanding global adolescent health. So thank you also for Dr. Fatima Safira Alatas, PhD, Dr. Dina Muktiari, and then Professor Dr. Risma Ladewi, and of course, Dr. Bernie as the lead of our lecture. Adolescent is still a problem in Indonesia, Professor Susan, and then all our student resident here, because we know we want to fight the maternal mortality, the newborn mortality, and then also stunting. And we know that maybe right now still more than half of our adolescent girls is already pregnant. So adolescent pregnancy is very, very high in Indonesia, and it supports a lot of things. So we need our adolescent to be healthy. So if we cannot prevent them of having babies or having their pregnancy, then at least they're already healthy. So we already have our our ministry and our law that to prevent them to get pregnant and to be married, but still we have adolescent pregnancy in Indonesia, and it support and it is in the backup the problem of preterm and also low birth baby in Indonesia. Most of our adolescents, if they are pregnant, they are in anemia, and they also have a very bad chronic energy malnutrition. So it is also the problem, except that, and some of them also obese. So both of them is not good, obese and chronic energy malnutrition. Obesity in Indonesia nowadays around 20%, Professor Susan, and chronic energy malnutrition is around 15 to 17%, and it is more to our adolescents to have the chronic energy malnutrition and anemia. So I'm happy that we are here to talk, to discuss about, and to understand more about the adolescent health globally. And thank you, Professor Susan, who will be our speaker today, and Dr. Bernie again as the moderator. And I hope that through this occasion, all participants will gain significant insight and knowledge around the topic. I also like to convey my sincere gratitude to all the supports or sponsorship that also have made in this event possible. Again, thank you. I'm very eager to hear your lecture, and then all the participants I hope that you will ask more questions because we should prevent this happen in Indonesia, the problem of adolescent. We need Indonesian adolescent become more healthy than before. Thank you so much. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Professor Ovi, for a very nice welcoming speech. And now we come to our scientific lecture from Professor Susan Sawyer. She's very well known for in adolescent health area. And then as I mentioned just now, that she's also pediatrician by training, director of the Center of Adolescent Health, Australia's leading academic center of excellent adolescent health. which is based on Royal Children's Hospital and Murdoch Children's Research Institute. And also she was the former president of the International Association for Adolescent Health. And so I'm very happy. It's my pleasure to welcome you, and I will give to you then, Professor Susan Sawyer. Over to you.
Thank you, Bernie. And I'm just trying to find my, I've got so many windows open. Let me just keep going for a minute. Here we go. Okay, can you see that?
Yes, yes, but it's not.
Okay.
Yeah.
Great. Let's go up to the start. Terrific.
Okay.
Okay. Selamat pagi. Bernie, thank you so much for the invitation to speak, and my warm regards to, or my congratulations to you for putting together this elective for your students, and my warm regards in particular to all of the students. But I'd also particularly like to thank the Dean, Prof. Ovi, and also for your generous words, Dr. Safira Alatas and Dr. Dina Muktiati, that we know that the effort that goes into putting together medical courses is a cast of thousands, and leadership is so important. And I must say, when I was a medical student, and this is me at your stage, when I was a medical student in an infectious diseases ward on the left when I think I was a final year student, and then in the middle here when I was on my medical elective in Pakistan, so learning all about the challenges of stunting and of multiple births and malnutrition. Now, this is going back a long time. I'm in my early 60s, so I enrolled, I think, in 1980, graduated in 85. But the reason to show you these slides of me at your stage as a student was that I received absolutely no teaching and no training in adolescent health. And I, as Bernie said, I embarked upon pediatric training, and then I decided to specialize in respiratory pediatrics. And my exposure to adolescents was really in terms of looking after young people with a chronic respiratory condition called cystic fibrosis. And I learned everything about adolescent health and adolescent development from that cohort of young people. And I thought that as medical students with your future directions ahead of you, I'm going to be speaking in the first half, giving this global perspective of adolescent health. But then in the second half, I'm going to bring it back to some very clinical skills, working with young people with chronic illness, with the recognition that this is relevant for every sort of chronic disorder that you might be looking after in adolescence. So I hope that there is something here for everyone. But coming back to when I was a medical student again, and perhaps when I was also training as a respiratory pediatrician, and even then in my early years of adolescent health. So I decided then to do further training in adolescent health. This journal, still the Journal of Adolescent Health, based in the States, was the journal, still is the leading adolescent health journal. But the focus was overwhelmingly on papers from high-income countries. When we published papers from Australia in this journal, they were seen as global. You know, Australia was viewed as foreign, and I don't think there was hardly a paper in the whole year of publications from low or middle income countries like Indonesia or indeed the rest of the world. Adolescent health was completely neglected, apart from really in the States. That started to shift somewhat in the, basically 20 years ago. And in particular, I'd like to acknowledge the Lancet Medical Journal. And it basically had its first series on adolescent health in 2007 that it asked us at the Centre for Adolescent Health to lead. And following this first series, where we had just a range of papers on a range of topics, including chronic illness that I led, one on sexual reproductive health, one on substance use, one on monitoring health outcomes, one on primary care, adolescent-friendly health services. But the editor, Richard Horton, invited us to come back and develop a second series But Richard, as the editor, very much wanted us to have a more global perspective than what we had in the first series. And so between the first and the second series, we then published a range of papers that were led by, in particular, by George Patton, based at the Centre for Adolescent Health, who at that stage had created links with the WHO Department of Child and Adolescent Health. And these papers were really the first papers that brought a more global perspective, informed by data about what was the burden of disease, the mortality, the morbidity affecting young people, not just in high-income countries and around the world. And it was these first two papers in particular that were critical in terms of highlighting that it's not just under 5-year-olds that die, but that adolescents also die. And it articulated what conditions they died from, what sorts of countries they died in. And up until that first paper that was published in 2009, if you had asked any professor of pediatrics, there are very few professors of adolescent health still in the world, but if you asked any professor of pediatrics how many young people die annually, what did they die from, or where they died, none of us would have been able to tell you the answer. So that then led to the second series on adolescent health in The Lancet that was published in 2012. And this then was right at the time when the Millennium Development Goals were, if you like, maturing. They came to an end in 2015. And in the lead up to the end of the MDGs and what then became the Sustainable Development Goals as the next series of global targets, each of the UN major agencies of relevance to adolescents started publishing a series of reports, many of them with wonderful titles. In particular, the UNICEF State of the World's Children report in 2011 for the first time focused on adolescence with this very evocative title, An Age of Opportunity. Up until then, adolescence has been very much framed as problems to be solved, rather than actually the opportunity that comes from adolescents who have greater autonomy and for which we as health professionals have a different opportunity to engage directly with them. Similarly then, in terms of, in 2013, this report called, again, a wonderful title, Motherhood and Childhood, about the problems that Professor Ovi had highlighted about the extent to which adolescents were actually parenting too young, and the implications of that intergenerationally for the health of their children. Perhaps strangely, WHO, which should be most responsible for the health of adolescents, was the last cab off the rank, if you like, the last of the UN agencies to lead a major report, but equally had a terrific title, Health for the World's Adolescents, Second Chance in the Second Decade. And then we then published the Lancet Commission on Adolescent Health, that the leadership of the Lancet after the second series came back to us again and said, we don't think the job's done yet. And they invited George Patton and myself to lead what was called a commission. And a commission is basically, well, a series that the Lancet had actually led is sort of 4 or 5 papers on a single theme published in the same edition or in subsequent papers that sort of pull together as a coherent theme of papers. Whereas the Lancet published, and I think their first commission would have been about, I think it was about 2011. And so a commission is really aiming to address a wicked problem that can't be solved simply by pulling together academics from a single discipline, but needs a diversity of people coming together and really trying to outline what we think the problem is, but how we might map a path to some solutions. And so the Lancet Commission was published in 2016. It has been incredibly well cited, and it has been incredibly well supported by the various UN agencies, particularly WHO, UNICEF and UNFPA. The quote on the front cover that I've expanded here, I think really highlighted this language of the transformative power of adolescence, transformative in their own lives, adolescence as a transformative period within our life course, but adolescence as also having this transformative power to change communities. And you guys are probably still too young in terms of your own life courses, but what I would like to do would be to just quietly invite the older folk within the faculty to be reflecting on what has been influential in your own lives. And certainly, as I said, for me in my early 60s, if I think back to the decade or 15 years or so that have been most influential in my career, and certainly it's adolescence. We happen to be very lucky in the coincidental timing of the Lancet Commission, which really was right at the time then of the Sustainable Development Goals. And what was incredibly exciting back then was recognising that rather than simply having a global strategy for women's and children's health, which had previously been the global strategy of relevance, there was the launch of the Every Woman, Every Child agenda that for the first time was a global strategy that was not just women and children's health, but also adolescents' health, with the commitment from the UN Secretary General at the time or the recognition that adolescents are central to everything we want to achieve and to the overall success of the 2030 agenda, which is obviously the Sustainable Development Goal agenda. And it's really interesting to appreciate that we're halfway through. Now, in the Lancet Commission on Adolescent Health, and in the next few slides, I really just want to highlight some of the key messages that we shared within that. This was our definition of adolescence: a profound period of human growth and development in which the assets and capabilities that underpin future adult health and well-being, social relationships, parenting and employment are established. Assets and capabilities. It's all about how we invest in this huge developmental window with the knowledge that we will recoup that investment later in the life course. And this was a very different way of thinking from previous thinking of adolescence being a brief period of turmoil, something to be just got through as quickly as possible, but no one invested in, to recognising adolescence as, if you like, a foundation for future health. I mentioned this notion of adolescence within the life course. What do I actually mean by that? That really, we spent a lot of time in the Lancet Commission, or I spent a lot of time developing up a series of figures to try and articulate this. And this is one of the figures from the Lancet Commission. I think of this as the butterfly diagram. There's the worm, if you like, of the butterfly, the body of the butterfly, that's this horizontal life course. And then the wings, if you like, are the needs on the top, matching the actions at the bottom and sort of flapping between. But if we focus on the horizontal life course, we can see that there's preconceptual health leading to, that's the maternal and paternal health, leading to then conception, fetal development, early child development, into adolescence, then into adulthood, then into the next generation in yellow, then going around, then preconceptually fetal development all over again. And the language of the Lancet Commission, or one of the most famous, if you like, or well-known memes that have come out of it, is this notion of investing in the triple dividend. And investing in the triple dividend was framed as the investing for benefits during adolescence itself. So that on the top here, if we invest in trying to prevent health problems, invest in reducing health determinants and health risks, we will have better health during the adolescent years. So that would be fewer deaths from suicide, fewer road traffic incidents, fewer deaths in pregnancy, for example, fewer deaths from cancer if we get these investments right. And if we invest in adolescents in the health determinants as well, then we will have healthier adults. So investing in nutrition, for example, so that we have less overweight and obesity, then we will have fewer NCDs in adulthood. I'm just going to put my phone on mute because I am needing to take a call. My apologies. My apologies. My husband has very severe cancer at the moment, and that was the palliative care service that I needed to take a call from. Where was I? Okay, so investments in reducing the non-communicable disease burden in adolescents then get recouped into adulthood. I mentioned the importance of investing in healthier nutrition, but whenever I'm talking to Indonesians, that probably the biggest determinant that will impact upon future adult health is tobacco in young men. And if we can stop young men from starting to smoke in adolescence and young adulthood, then we will have far fewer premature deaths from tobacco-related disease in later adult life. And then the third aspect of the triple dividend is if we can have healthier young people and young adults when they choose to parent, so less in the way of substance use, less tobacco smoking, better nutritional status, better mental health, more educated young people, then the health of the next generation will be much better. So this notion of the triple dividend. When I was a medical student, all I learned about adolescence was puberty, the timing of puberty and the significance of puberty for reproductive capacity. So the end of puberty, young people by definition are then physically capable of reproduction. I learned far less about the importance of puberty in terms of its impact on the linear growth. And so on these two graphs here, I've put the peak height velocity, so how many centimetres per year girls are growing on the top pink graph and boys are growing the bottom one, which demonstrates that the peak age, if you like, of the fastest that girls are growing is at 11.5. And these are dimorphic patterns, difference between the sexes. So for boys, it's 13.5, 2 years later. The vertical line I've dropped here is at the age of 10, just to bring that to you. So I sort of learned a little bit about secondary sexual characteristics, importance of puberty on one hand, but didn't really learn anything about height velocity. Did learn about Tanner staging in terms of how we measure that. Increasingly, however, what we know about the importance of physical development is not just the importance of puberty, but the importance of what puberty means in relationship to brain development. So the pubertal cascade basically then sets off a wide range of aspects of brain development of different parts across the brain, from the subcortical maturation that occurs first through to the prefrontal brain, that then is, if you like, shaped by the nutritional, physical, social and cultural environments in which young people are maturing. So that our brain development doesn't just happen automatically, it happens in response to these social and physical environments among us. And if we get those social and physical and cultural and health environments right, then at the end of adolescence, we will have young people who are ideally at their fastest, fittest, strongest and smartest. And so this notion of the investments that we are making in all of these environments is in order to maximize those human capabilities that we see at the end of adolescence. And I've just basically had a different way of describing it with this figure. It's basically saying the same thing. There are different parts of the brain. I put this cartoon up here. But on the right, you can see that it is the limbic part of the brain that develops before the prefrontal cortex. So the limbic part of the brain tends to develop earlier. This is the dopaminergic responsive part of the brain, responsible for emotions, for rewards. I think of it as the roller coaster part of the brain that gets sort of excited by doing, really exciting things, particularly with other people. Whereas it's the prefrontal cortex that develops last, development continuing till the mid-20s. That's much more that part of the brain responsible for your success as medical students in terms of planning, in terms of investing in studying rather than going out partying every night, because you have this commitment to your future and that recognition of the importance of delayed gratification. So it's all about your ability to have emotional regulation and delayed gratification for perceived future benefit. Now, people talk about it's as if God developed the human brain and connected the accelerator before the brake, and that we become adults in a sense with when we have both a functional accelerator, the limbic part of the brain, as well as the brake, the prefrontal cortex, and that adolescence arguably is this time in between. And whilst it's a bit simplistic, I actually think it's quite helpful to be thinking about what is the strength of adolescence, that they can get incredibly excited by all of these things happening in their world, but they can be challenged by the absence or the still emerging capacity. It's not an absence, but it's still the emerging prefrontal cortex, which is where, in a sense, the importance of the parental role still comes into being for adolescents. And I'd like to demonstrate this with a figure by Larry Steinberg's group, a US neuroscientist. The instructions for individuals were who were seated behind a computer screen, and it was a computer game of a racetrack. And the instructions to each individual undertaking this computer game were to drive as fast and as accurately as you can. And on the y-axis here, this is the number of mistakes that each group made of adolescents, young adults, and older adults when they first undertook this test alone by themselves in front of the computer screen. Now, the experimenters then asked each subject to invite 4 or 5 close friends to get them to stand behind them silently when they repeated the test. What do you think happened? What do you think happened to the accident rate for the 3 different groups? Those of you who thought that the accident rate went up for adolescents in comparison to other groups are correct. And it's interesting when we think about peer pressure, that, you know, so much we think about that as perhaps something that peers intentionally or explicitly get other kids to do who otherwise perhaps wouldn't be doing that. But remember, these peers were standing silently. They were not allowed to have any discussion or engagement with the experimental participant. So this is internalized aspects of wanting to do well in front of one's peers without the same ability to concentrate and regulate our responses as older adults have. And remembering, this is with adolescents who have got far better hand-eye coordination because of far more hours spent on computer games than we as older adults, although perhaps that's balanced by our greater years spent driving. Back to the Lancet Commission in terms of brain development and the importance of peers. This is another figure that we developed for the Lancet Commission. I refer to this as the sperm diagram, to sort of signal that if we look at the life course on the x-axis here, and these are the proximal social determinants that are layered as the rows, if you like, on the y-axis. And it's basically trying to say, if we start firstly at the swathe of pink or purple below, to say that family is important across the life course. But it's during the adolescent years that there's that transition from family of origin to family of one's own. But it is during adolescence that there is this major transition from completion of education through to employment, and a very dynamic social context in terms of it is the time in the life course where there is the greatest influence from peers, and indeed also from the media as a super peer or an uber peer. So this is an incredibly influential, changing, dynamic time across the life course. And at the same time, when we think of these Harry Potter characters, and I've put up this figure of them at the first launch of the first movie, when they were 12 or 13 in early adolescence, and then 10 years later, nearly 10 years later at the final premiere, when they were in their early 20s, and we can see the tremendous physical differences between them. But if you think of all of those Harry Potter movies that I'm sure you've seen as much as me, you can appreciate that, in a sense, adolescence is all about standing out, developing one's own identity and pursuing one's autonomous interests distinct to one's family, And we do that in a sense by concurrently needing to feel that we are fitting in by gaining a sense of affiliation and acceptance from peers. So very different challenges. On one hand, standing out, on the other, fitting in. And then similarly, it's about measuring up and taking hold, a sense of developing competence, finding ways of achieve, and making commitments to particular goals, activities, and beliefs. And if we can't succeed on the sporting field, on cultural pursuits, or educationally, then a number of young people will find ways of developing a sense of achievement, whether that's in being in gangs, whether that's competing for antisocial behaviour. Young people have a way of finding a way of feeling powerful within their own social environment. So let's move then to thinking about the health issues that affect young people. We've talked about some of these already, but within the Lancet Commission, we grouped all of the world's ICD-10 codes into these 9 disorders, and then we grouped those into 3 different sorts of conditions. On the right, non-communicable diseases. In the middle, accidents and injuries, including both unintentional injuries, violence, road traffic accidents. And on the left, what we call diseases of poverty. This was infections and vaccine preventable diseases, undernutrition, HIV/AIDS, and sexual and reproductive health, which was effectively maternal death. And we had some fancy algorithms by which we counted this using model data from the Institute of Health Metrics and Evaluation, because in so many parts of the world, primary data sources are not fully available, particularly in low and middle income countries. What we were able to do when we looked across these different conditions was to really chart what's described as an epidemiological transition, namely how the nature of diseases and the prevalence of diseases changes with growing wealth in individual countries. And so what we were able to show was when we grouped this disease burden by countries, and for each of these, and I'll go through it, we can see that on the left of each panel is from 1990 through to 2013, so now 10 years old. And you can see that on the left is NCD predominant, females and males. In the middle, injury excess, again, females and males. On the right, multi-burden. And you can see on the right here that we have, and if you can see all of the colours of these 9 different sorts of questions. So I hope you're oriented a little bit. I appreciate it's a bit complex to see. But you can see that in these in these multi-burden countries, or countries where there's high levels of poverty, you can see that the excess burden is very much from infectious diseases, from maternal mortality, from HIV/AIDS, and from undernutrition. This is particularly anemia. In the middle, you can see that it's males have the predominant excess from accidents and injuries. But in all types of countries underneath, if you can eradicate your excess burden, that you have a heavy burden of non-communicable diseases in terms of chronic physical injury and also mental disorders. And so the reason that in the second half of this talk, I want to talk to you about chronic physical disorders is because this is common in all countries. So that in the Lancet Commission on Adolescent Health, where we really got to was really signalling that we need to think differently on the nature of the disorders that constitute adolescent health, moving away simply from a focus on sexual and reproductive health, which had been one way of thinking about adolescent health. Really the only focus had been on premature pregnancy, to thinking about a much broader range of health topics, including mental health, substance use, nutrition, particularly not just undernutrition, but overnutrition, as Prof. Ovi mentioned, also accidents and injuries and violence. We needed to move from thinking just about clinical care to bringing much back in terms of thinking about social determinants and how we can be investing in prevention as well as health services. And in particular, I'd bring attention to the role of schools. And so in the Millennium Development Goals, there was very much a focus on the importance of primary education. But in the Lancet Commission and in the Sustainable Development Goals, the focus is much more how can we be investing in ensuring and maximising 12 years of education and in quality education. And we signalled in the Lancet Commission that actually 12 years of quality education is probably the best investment that we can make in adolescent health. And I've used the example of pregnancy outcomes here, that if we move from primary to lower secondary education, that there are 48 fewer births per 1,000 girls. And then in comparison to girls who have upper secondary versus lower secondary, there's 68 fewer births per 1,000 girls. So more educated girls not only choose to parent later, but choose healthier approaches. They're more likely to breastfeed, more likely to immunise their children, more likely to have some power in their households by which they can choose to make healthy decisions on behalf of their children. In the Lancet Commission, we also then, as I'm sort of starting to signal, framed new views on which sectors are responsible for adolescent health, moving simply from the health sector, from hospitals and community health, primary health care, and WHO, through to education, employment, welfare, justice, and that recognition actually that adolescent health is every sector's responsibility. And there were then new views on what age constitutes adolescence. WHO historically in the mid-60s defined adolescence being from 10 to 19 years of age. 2 5-year demographic bands, 10 to 14, 15 to 19, and demographers count up the world in terms of these 5-year age bands, 0 to 4, 5 to 9, 10 to 14, 15 to 19. Bernie Medise described in Indonesia that you define adolescence as 10 to 18. In the Lancet Commission, we strongly recommended that adolescence extend from 10, not just to 19, but up to the mid-20s, up to and including 24. So 3 5-year age bands. And we did this and defined this, if you like, new or expanded definition of adolescence because of the appreciation of the importance of adolescent brain development extending into the mid-20s and the significance of what this means in terms of health. And so just because at the age of 18 in most parts of the world, we might have legal maturation in terms of being able to sign contracts, in terms of being able to legally get married, in terms of in Australia being able to legally buy alcohol from licensed premises, for example, or drive a car, that there's no singular age that has been used to define adolescence. And that increasingly the language of adolescence and young adulthood is extending from 10, if you like, being early in the timing of puberty with, as I said, 12 and a half being, or maybe I didn't say it, the average age of menarche, 12 and a half first menstruation is pretty early on in adolescence, but then extending all of the way through. So I'm going to pause now in terms of that as an overview of, if you like, the global significance of adolescence, signalling that Indonesia is not alone in being a country that is only, if you like, just starting to grapple with moving from the investments that your government and that your health services have historically made in under 5-year-olds to really now thinking to be, how do you lift upward in age and to think about investments in adolescence as well as younger children. This is obviously particularly relevant for those of you who are working in paediatrics and children's services, but is actually relevant most in primary care. It's highly relevant for those of you who move into subspecialties in adult medicine as well, in terms of thinking about needing a skill set to be looking after adolescents, caring for them, working with their parents, regardless of whether that's in primary care or specialty settings. So moving into the second half, what I really want to highlight is thinking about how do we care for adolescents with chronic health issues, whatever they might be. And this is where we need to take on board what I call Adolescent Health 101, those key messages that consultations with adolescents are opportunities for learning, for adolescents to learn. They're also opportunities for us to learn from them. That knowledge of adolescent development, what I've just gone through with you now, is central to our engagement with adolescents with chronic health conditions, but particularly that routine psychosocial history taking is central to quality consultations. That's the basics. The more advanced aspects is thinking about how do we work with young people and their families to promote adherence with the treatment regimens that we wish them to undertake. And the reason to suggest that is that we know that we learn a hell of a lot about the best treatment of the disorder when we're medical students, and we continue to be very much invested in that in our early years of medicine. But actually, the best treatments in the world are unable to be, if you like, to be valued, unable to have to be optimized unless actually young people are actually able to engage with them and take on those treatments. So if we think about young people with asthma who might be on a twice daily treatment regimen, or the need for young people to take an iron supplement on a regular basis, if we cannot work with them to be engaging their understanding of why they should be doing that and helping them to define habits that might make it more likely that they actually take the medication, supervised ideally by their families, then the best treatments of the world is going to be meaningless. So yes, your job absolutely as students is to learn all about the best treatment of whatever the disorder it might be that you're learning at the time. But if you can't put that into practice with young people themselves, and young people are a very critical audience, then we will fail again and again. So why do we fail? I love this cartoon here by an Australian cartoonist, Looning, because many of us, when we first start working with adolescents, and for many years yet always feel a bit like this Looning character here, you've sort of got the elements right, but you haven't got it in the right position, if you like. You know, the fish on the feet should really be in the fishbowl, and the shoes in the fishbowl really should be on the feet. So what are the core elements? And I'm going to use here, this is a real kid who I saw many, many years ago now, but who I still use as a very exemplifying case. This is young Amy. She was a 16-year-old girl at the time who was in the middle of her secondary school years. She had a chronic respiratory illness and had been seen at 3 monthly intervals at the Royal Children's Hospital for the past 2 years. And she was referred by her GP to the hospital emergency department because of 3 days of a sore throat. In the emergency department, she was noted to be febrile. She had unilateral tonsillar enlargement, and they correctly diagnosed that she had a peritonsillar abscess. The old-fashioned word we use is quinsy. And she was promptly treated with intravenous antibiotics and was referred to the hospital's ear, nose and throat department. And she very quickly, within 24 hours, underwent surgery. And at the time that the medical student was sent to see her, she was waiting to be discharged home. And the medical student was undertaking training in adolescent health, a pair of lectures. And the task was that they had learned how to take a psychosocial history, and they were going in pairs to find a patient to take a psychosocial history. So the patients took a psychosocial history. But if I was to ask, and I'm going to share that with you at the minute, but if I was to ask the doctors involved who were looking after this patient, whether they were in the emergency department or the ear, nose and throat doctors, whether they thought they had provided quality care to the patient, I'm sure all of the doctors would have said absolutely. No, this patient had the best diagnosis, she had a prompt diagnosis, she was treated really well, she had no acute complications, and she was discharged within 24 hours. We've done our job. But the medical students then took psychosocial history confidentially from her father. They identified that she lives in the country with her alcoholic father, that she drinks large amounts of alcohol regularly, that her father provides for her, and that she had been sexually assaulted the previous year by a 30-year-old friend of her father's when she was drunk, and that for the last year, really, that she had been depressed and had made 3 active suicide attempts in the last 3 months. So the question then is, well, is this quality care? And I think the answer is we would have to say no. You know, to me, this doesn't pass the Herald Sun is the name of one of the newspapers in Melbourne. You know, this doesn't pass the Herald Sun test. You know, if this patient had committed suicide the day after she was discharged from hospital, would this pass the Herald Sun test? No. But really the question then becomes rather not, is this quality care? Because that's too easy. The answer is no. But really, whose job is it to address these issues? Was this the job of the Department of Respiratory Medicine, who had been seeing this girl for her chronic health problem for the last 2 years, every 3 months? Their focus was on the chronic health issue that they had, not on the social context. Was the responsibility with her GP, who had hardly seen her at all over this time? Most young people see their GP about once a year only. Was it the responsibility of the emergency department to assess this when she rocked up for what is otherwise, you know, an acute life-threatening complication? Was it the responsibility of the ear, nose and throat surgeon or the nursing staff when she was in hospital? We might all, if we were those individuals, or was it the responsibility of the medical student? I think the one person that we could agree that it wasn't the primary responsibility to take charge was the medical student, the only person that for this patient who actually did identify the problem. So you guys have got an important role. But I think if we were each to say, well, it's not our responsibility, not in my backyard, I've got other responsibilities, then we would all, as a system, be failing the patient. So I think the priority here is trying to identify whose responsibility is it as a system, because as a system, it's all of our responsibilities. Let me tell you then about another patient and try and sort of put this into practice a little bit more. This is Kate, another patient of mine that I learnt a lot from very early on when I first returned to the Royal Children's Hospital from completing my respiratory training in Boston. She was also a 16-year-old girl, had chronic persistent asthma. She'd been managed by the Children's Hospital Department of Respiratory Medicine for many years, where she was known as the helicopter kid. She had been medevaced in from outer suburbs at least once a year for the past 3 or 4 years because of acute, severe, life-threatening asthma, which she was then taken to the intensive care unit. And the physician looking after her had thrown up his hands in disgust, saying, I don't know what to do with this kid. She's too hard. She refuses to do anything I wanted to do. I don't get it. There's something else going on here. Susan, can you see her? And I had very little confidence at that time. You know, I'd had very little experience with adolescents at that time either. But I started seeing Kate. And so one of the things that I started to think about with this young person was, how do we conceptualize what quality care might look like for a patient with chronic illness? And so we had done some research around this time where quality care or self-management is about trying to understand what expectations we might have for patients and their families. What do we identify as what's developmentally appropriate for an adolescent? What are the specific tasks or the generic tasks, by which I mean, what does a young person with asthma need to do to look after themselves? But what would a young person with any chronic illness need to be looking after themselves? And how is it that within the system we empower, educate, and equip young people so that they can manage as much of their chronic condition as they're able to do so? And very importantly, how do we then educate, equip, and reassure parents to support them to step back from holding primary responsibility to enable young people to step up? So we did some work which was really trying to identify what are these specific management tasks. And for a young person with asthma, this is all of these. I'm not going to go through these, but basically I just want you to take away the idea that there's a lot of things that young people have to learn how to do. What to do, how to do it. This is complicated. Looking after oneself, self-management of a chronic disease is not straightforward by any means. There's a whole lot of things that young people need to learn how to do and undertake, including at the most basic, paying for healthcare. So financial independence from parents is obviously one of them. So how do we teach young people how to do this? And beyond how those, if you like, those medical tasks, how do we also work with young people to articulate the self in self-management, for them to be able to positively identify that they do have a chronic condition? It means they are different from other people their own age. They have to do things to look after themselves, everything on that last slide, that other people without chronic illness their age don't have to do. And they have worries that other young people don't have. Because if they don't do that as a positive identity, then the risk is they will be very resistant to us in healthcare asking them and inviting them to do things, and they will be insisting, I'm just like everyone else and I won't be told what to do. Go away, if you like, that denial of having a chronic illness. Now, one of the ways, of the most powerful ways we have of engaging young people in self-management is actually seeing them by themselves for part of a consultation. This doesn't mean that parents don't continue to have major and primary responsibility for supervising young people's treatment regimens. But the more that parents continue, if you like, to supervise directly young people and speak for them within health consultations, the less that young people will step up and themselves learn to take responsibility themselves. This was a study done many years ago now in the US of young adults with cystic fibrosis in their early 20s, asking them at what age would they have liked to have started to see the specialist for some time by themselves. And interestingly, you know, my team in Melbourne always jokes that the 13-year-olds are likely to be girls and the 16-year-olds are likely to be boys. But look at the proportion of the proportion of young people in their 20s who said right from the age of 12 or 13 would have been the right time to have started to consult with their specialist alone. And the value of starting to consult with a specialist alone is in order to be able to frame a safe space where there is no such thing as a dumb question. So confidentiality is not just because there are sensitive topics that you might like to discuss. As important as that is, and 1 in 4 young people do not trust us to keep information confidential from their parents and don't share it with us because they're fearful that that their parents are going to find out. But that this is a safe space to be asking the sort of questions that young people may not otherwise be able to ask because they have the expectation that they should know this when actually they don't. Their parents might know it, but they don't. Now, I've mentioned before this notion of psychosocial history taking. What is it? In Australia, we use this framework of HEADS for a psychosocial history, HEADS. That's just an acronym, and there's many other E's and A's, and in Australia, extra S's for fun, smart behaviour and extra S's for safety in terms of sort of sexual abuse. But I tend to use this more sort of simple framework of asking questions about home, education, activities, drugs and alcohol, sexuality, and suicide, depression, self-harm as the mental health set of questions. I don't ask them in a ordered way. I don't ask them in a singular linear fashion, but rather I often start a consultation by asking questions about education and schooling firstly, about activities is often where I start, then go into home and do then keep the latter half of the psychosocial history taking, particularly when I've got to know a young person a little bit more. I have certainly found, and I continue to use this approach even though I'm now very experienced consulting with young people, because I haven't found a better way of engaging with young people, of assessing sort of where they're at with adolescent development. Are they a very young adolescent or are they more mature and slightly more sophisticated? Obviously, you can identify health risks, but you can also identify a set of protective factors such as a young person who's very engaged with their studies, who's wanting to go on to university, who might come from a wealthier, more supportive family. And then in terms of their interests and activities, it's often a way that I can then help formulate an intervention back to young people in ways that make sense. And I use this language of adherence hooks. And thinking back to my young person with asthma, because I'm going to come back to Kate in a minute. If Kate was a really sporty kid, then I might use the example of trying to get her asthma under control in order to make her competitive with sport. Now, she wasn't a sporty kid. If there was a school camp that I knew a young person wanted to go on in, say, 6 weeks' time, maybe I could use the hook of that, because perhaps if her asthma wasn't well enough controlled, her parents might not allow her to go on the camp. If it was a really educationally engaged, academically inclined student, I might use the hook of reducing school absenteeism from asthma as the mechanism to be promoting educational achievement. But if you can't find anything else, then getting mum off your back is certainly in Australia a very powerful adherence hook by getting young people to take more charge. So let me tell you about what I did with Kate, our helicopter kid. What I did was to describe to both Kate and to her mum my approach of working with patients like Kate. And I said that I would start to see her alone for the first part of each consultation, and then I'd meet together with her mum for the latter part. And I was very reassuring to her mum that this wasn't prematurely dislocating her mother. It wasn't a parentectomy. I was very clear, firstly, to Kate that I wanted to hear from her, but also very reassuring of her mother. And I discussed with both of them the role of confidentiality. I then talked about how I would be, when I was then talking with Kate alone, I then talked to her about taking a psychosocial history. And then I sort of really framed after I'd done that, and this was after a few consultations, framed to her and to her mum the fact that Kate really wasn't owning her fact that she had asthma, and that I was myself appreciating that this was because what Kate described as maternal nagging, I didn't frame it as that. Mum was needing to remind her because Kate wasn't engaged herself. But there were a complex set of family issues as well that were also getting in the way. Now, what we did was to work with Kate to identify a short-term goal, which for Kate was to stop her mum nagging. The way we did that was to get some treatment routines established that her mum could supervise, and only if Kate had then done them. Her mum's role was not to nag, but was to congratulate Kate. I reviewed her very frequently, fortnightly, for a couple of weeks, and we problem solved and got Kate involved in finding solutions and very actively engaged Kate's mum. And in the end, I actually ended up referring Kate's mum for some mental health support for her own issues around parental separation and her own anxiety, which was getting in the way. We identified, we had lots of discussion. I'm not going to actually go into these things now, many patterns that were influencing adherence, many factors influencing adherence patterns. But many people on the right refer to patients as being adherent or non-adherent. I think very unhelpful. We need to recognise that most of our patients have variable adherence, that they're adherent to some parts of a treatment regimen some of the time, and partial adherence is much more common for a range of these factors on the left here. However, asking about adherence behaviours, I think, is a really important thing. When I was a junior doctor, what I would ask of patients like Kate was, so how is your, and I was very interested in adherence as a junior doctor, but I had this very positive stance where I would say something like, so how's your asthma going? Is everything going okay? Are there any problems? And I had this incredibly sort of enthusiastic stance. So if things were not going okay, you'd have to have been a fairly brave person to have shared with me that, well, actually, no, there were a few problems. In time, and I came across some studies that said that people who said that they were not adherent were very honest that they weren't, whereas people who shared they were adherent were often not particularly reliable in their self-accounting of their behaviours. So then I tried to make it more easy for people to admit what they weren't doing. So then I tended to ask something like this. Most people I see have difficulty putting their medication into their day, what I would call a normalising statement. Tell me, how are things going with you? How often are you forgetting to take your medication? And using this approach, I certainly had many more patients and their families who were acknowledging that actually they were forgetting a lot. So that language of forgetting has no shame about it. Whereas then I moved on to, and this is still the approach I use mostly now, most people I see have difficulty fitting their medication into their day. First, can you tell me if you're taking any at all? And I would pause. And about 10% of my patients then would fess up, well, actually, no, I'm not taking any. And for some of them, actually, it was a good reason that they weren't. But if they were then they're taking medication, tell me then, which dose are you more likely to forget? So this is for asthma, twice daily medication, the morning or the evening dose. And then straight away, you can get into some troubleshooting about why they might be better at remembering the morning dose or the evening dose, and to try and look at them developing some habits. So I've certainly completely changed my approach to asking about these behaviours. So my take-home message for you as students, and I appreciate that what I've gone through is perhaps a much more sophisticated approach than what you as students are expected to be able to undertake, but I have high expectations for you guys doing your, particularly for those of you doing your month medical elective. But adolescents are still learning about their health and about well-being. And every consultation, whether that's with a consultation with a young person with a chronic illness, or indeed for whatever you're seeing, is an opportunity for their learning and also for ours as health professionals. Consulting with them alone and taking a psychosocial history confidentially are central to quality care for adolescents, particularly those with complex health conditions. And adherents, do not assume that young people are doing what you asked them to do at the last consult, rather assume that they don't, because adherence is challenging. The science suggests we can't predict which of our patients will be adherent, and so efforts to improve adherence should be integral to every consultation we have. Finally, a few further take-home messages with adolescents. Be respectful. If there's one thing, be respectful. Adolescents have got a fake monitor, a fake radar. They can detect if you're genuine or if you're fake from a million miles away. And they only will respect you if you are being genuine with them. But be curious. I found the best personality skill of an adolescent physician is to be curious. Ask questions. Why? Seek deeper understanding. Ask for their beliefs about whatever it might be. It's the best way of engaging with young people. But certainly another way to be asking is don't make assumptions that they know anything. And the only way that we can assume nothing and try to understand what they do know is by asking. By asking young people, we are actively engaging them in their own health. I've put this a picture on the left of a young kid with trainer wheels, if you like, which is sort of trying to highlight that role of the parent being the trainer wheels for the kid on the bike, supporting them along the way. But basically, none of us want to stay with our trainer wheels forever. We want to be like this young person on the right, flying safely through the air. And that means that actually young people need to be learning to engage with us when their family is still around, for them to be able to sort of make mistakes safely and learn from them when they're still with their parents and ideally still in the paediatric system. WHO refers to adolescent-friendly health services as being services that embody these skills: psychosocial history taking, respectful engagement with young people. Too often people assume that this is only in relationship to adolescent sexual and reproductive services. It's not. This is about every consultation we have with a young person for whatever reason. And if we think about health services as a system, we can sort of really think about these different elements in the middle here in yellow about the sort of things we need to be thinking about modifying. And I would be hoping that these are some of the sorts of things that you might be thinking about in relationship to your own medical electives. We've got policy context or frameworks in terms of our adolescent-friendly health services and our core competencies on the left and the right from, say, WHO. But within an individual health service, what does this mean for the age policies? Does your service stop at the age of 14, or might it extend up to 19? What does that mean to transition to adult health care when your patients graduate from your health service? How do you then engage with them in adult services? What are your policy statements around clinical guidelines for confidentiality? What is the information that you might have available to be equipping parents to understand this? What about costs? we tend to think about subsidising healthcare for under 5-year-olds for maternal and child health. What about adolescent healthcare? If we think that adolescence is so much a foundation for future health, then surely we should be thinking about subsidising health across the developmental window, potentially for 0 to 24. What do we think about our waiting room spaces, our physical environments? If our adolescent patients are sitting constantly beside crying babies and young kids, do we really think they're going to feel as welcome as if we could be sitting them perhaps in clinics where there is a predominance of other young people so they can feel more like them? And how do we know what they might want unless we ask them? So thinking about development of youth advisory committees is really important. Underpinning, though, all of this is academic and clinical leadership. How are you going to do anything without the Bernies of the world, without your professors of adolescent health, without clinical leadership? I would really commend to you the professional association, ACA INAHA, the National Association for Adolescent Health in Indonesia, and also the International Association for Adolescent Health that I have previously been the president of. And also in the US Society for Adolescent Health and Medicine. So for those of you who've got a particular interest, it's really thinking about how do we best support the development of academic and clinical leadership so that in every country, and Indonesia, as you know more than me, is a huge country population-wise. You know, you've got over 70 million young people, that you are desperately needing academic and clinical leadership to be working with your hospital systems, primary care, training the next generation of medical students, of public health professionals, of government advisors to be making things work better for young people. Finally, I'd be encouraging within paediatric services to use language that makes adolescents more visible. Don't assume that when people refer to the language of child, it also is referring to adolescence. If we're referring to reducing childhood mortality, as the MDG goal number 4 did, well, that was under 5 mortality, not child mortality. So bring visibility with language. If we are really referring to, say, 0 to 18-year-olds, refer to the language of child and adolescent health rather than just child health. But if you're doing that, then review all of your organisation's policy documents, making sure that the language is also inclusive of adolescents and young adults within that. And that if it isn't inclusive, that's where you need to be working with your various policy groups to be changing, for example, your policies to be ensuring that they are inclusive. I'm going to be stopping my sharing slides there. I appreciate that we've had, as we would say in Australia, a cook's tour. Gone all over the world within a whole lot of ideas here. I'm sorry if I might have overwhelmed many of you, but I hope it's provided perhaps a bigger context for some ideas about how, from my perspective, there's no more exciting time to be in adolescent health. And in a country like Indonesia in particular, there is also no more exciting time because the world is your oyster. There are very few people in Indonesia who have got expertise in adolescent health. So for any of you who are interested in careers in adolescent health, there are many, many opportunities ahead of you. So I would really encourage you to think about it. And I remember, if I just finish on one thing, Bernie, I remember when I started in adolescent health, having had long-standingly an interest in global child health back then in my training as a medical student. And I remember one of our child health academics, he was relatively junior at the time, and he accused me of selling out to high-income medicine because adolescent medicine was framed as this sort of high-income thing. And I remember about 10 years ago telling Kim Mulholland, I hope you appreciate that I didn't sell out to high-income medicine, but actually we've brought a perspective of adolescent health globally, and I really commend this to you. So congratulations to all of you students. For your interest in adolescent health, I really commend this to you, and thanks for the opportunity, Bernie. Very happy to take any questions, and as I said, there is no such thing as a dumb question for my patients, and all of my medical students learn very quickly, and all of my trainees in the same way. There's never a dumb question, so please don't feel shy.
Thank you. Thank you so much, Professor Sawyer, for very interesting and very comprehensive lecture, I think. Yeah. we learned a lot from you. Just adding a little bit because some of the participants just came a little bit joining us late. So just a quick reminder that Professor Sawyer reminded us about some important points, yeah, that adolescence is the asset, yeah, and capabilities that underpin our future actually, yeah. And also that adolescent brain development is very unique, and the prefrontal cortex developed a little bit delayed until 24 years, I think, yeah, Professor Sawyer. And that we should put some important aspects, yeah, in dealing with adolescents, such as confidentiality, psychosocial history taking, and we should learn more about the making health services adolescent friendly. Okay, and then the last one that I think it is important for us dealing with academia, for instance, and also in universities, that we still have lack of publication on adolescent health. I think that's some points that important from Professor Sawyers. So now we come to the discussion. So for you who wants to ask question directly, you can just click the raise hand reaction at the bottom of the screen, or you can type your questions on the chat. So I think we have one already here. Dr. Zulkarnain, you want to ask questions?
Okay, thank you, Bernie, for the opportunity, and also good morning, everyone. Good morning, Professor Ovi, and every doctors and medical students, and especially Professor Susan Sawyers, who gives us really interesting topics, especially in adolescent medicine, and also emphasize to us the importance of it, because we sometimes neglect it when we consider on or want to increase our holistic approach to medicine. And my question is really simple regarding our condition in this country. The first is about, we know that Indonesia is known for one of the countries that has so many smokers percentage above 15 years old, which is around 28%, according to Indonesia Statistics Center. And the question is, what is the strategy from a Lancet Commission or any other commissions that are focused on adolescent health to tackle this problem, since the problem is considered to be a big structural problem, especially when we consider such as unrestricted ads on smoking. And this is not narrow only to smoking, because we see the recent phenomenon such as vaping that is also increased in Indonesia, especially for smoking regulation in developing country.
Yeah.
Thank you.
Delighted to get a question on smoking, because as you say, the figures are 28%, but that's overwhelmingly in males. And so it effectively means that, half of Indonesian young men are already smoking by their early 20s with, as we would all appreciate here, phenomenally damaging effects in terms of future health. This is a really good example where it's those, if you like, structural interventions that are required at a government level. There's the global framework for tobacco control that I really, commend to you all, and that really sort of signals a wide range of elements that need to be implemented country by country, year by year. Some of those include, and most of those include aspects that limit ease of access. So we know, for example, that for young people who are more cost sensitive than any other age group in the population, they have less money to spend, that taxation, for example, of tobacco, so having an excise tax that the government applies that makes individual packs of cigarettes more expensive, is one of the very powerful things that disproportionately reduces tobacco smoking in young people. But you really are needing to bring one's community along with you. So that in effect, in Australia, and I was interested to hear your comment about vaping as well, because I just actually tweeted at the weekend that my tweet was something like, can I look it up? It was shame Australia that our failure to address the vaping pandemic by not having tighter compliance standards and tighter regulations to limit the sales to minors of vaping materials risks putting back 50 years of the tobacco control agenda in Australia, where decade by decade we have seen, very persistently reducing prevalence of smoking in young people. But getting back to it, it is about actually firstly stopping smoking in the older adult population. And so that means, as I said, taxation, making tobacco expensive. It means putting in place community regulations these are government regulations to be banning smoking in increasingly defined spaces. So that would start off no smoking in government buildings, no smoking in schools, and then increasing, no smoking in hospitals, and then, gradually increasing that so that businesses then decide themselves that there's going to be no smoking, in any enclosed business space, such that when you then have the experience and comfort with that, and for non-smokers, the experience of how nice it is not to be exposed to tobacco smoke, you can then do the next stage of public policy, which is working to then be banning smoking in pubs and clubs and restaurants, in sporting environments. And this will only take place then, the support for that within the community and the community's ability to themselves, if you like, put in place those regulations so that business owners ask people not to smoke, only take place if those people really understand the risks of smoking. So that means there need to be public education campaigns on TV, on billboards, in schools, in the community, and that we as doctors need to be having discussions with all of our adult patients who smoke to make people aware of the harmful effects. So again, it's an example of where there's not a singular public policy, but a series of different policies. But probably one of the most important starting points is to ban all tobacco advertising, and then increase the cost of tobacco, to ban sales of individual sticks of tobacco because they're cheaper for adolescents, so to only buy a pack of 20 or 30. So that in Australia, I actually don't know the cost, but I think in Australia, a pack of cigarettes costs something like 30 Australian dollars. So tobacco is incredibly expensive in Australia. And it is now one of the reasons why vaping is becoming more expensive, but particularly vaping is becoming more popular, but particularly vaping is becoming more popular because it's being seen around as a trendy, celebrity-driven thing to do. And in the absence of compliance of legislative limitations, then vaping is becoming a major problem in schools. And we are expecting for the first time that our rate of smoking in teenagers in Australia might actually go up at the latest survey for the first time in 50 years.
Yeah, thank you, Professor Sawyers. Yeah, so I think I agree with you. Yeah, if I'm not mistaken, Australia is one of the countries that put very expensive for the tobacco cigarette. Yeah, and as you said, as Dr. Zulkarnain mentioned, also in Indonesia, vaping is becoming popular too among teenagers. And so we hope that your points could help us probably that we can educate, yeah, as you said, educate adolescents to probably better prevent, yeah, using it.
But this is where I think many of us when we talk about education, Bernie, I think it's interesting because many of us sort of think that if we are to be working in a prevention space with young people, it's all about education. And we might then think, oh, we need to develop a health curriculum in schools about the dangers of tobacco and the dangers of, say, vaping. And that's part of the solution.
Yeah.
But if I was wanting to stop vaping in young Australians of a secondary school age, I wouldn't start with a health education curriculum. I would start with some focus groups with young people. I would engage perhaps their drama teachers or their art teachers or their media study teachers, and to work with young people to charge young people with, say, the challenge of developing an anti-vaping media campaign. What would they develop if they were to share with young people the harmful effects of vaping? And so if we engage young people in telling us what they think the best solutions are, then they have to do the homework in terms of understanding what are the health impacts, why would they want to do this. It engages them creatively with some sense of ownership of this as a problem. And I tell you what, whenever I've seen any of the media studies or the videos or anyone else that any young person does in terms of, sort of creative pursuits, it's far more effective than anything I've ever seen any of us teachers or doctors do. So I think we can be much more creative in terms of how we do this with young people.
Yep. Agree. So that's why we have lots of young people here. So, but before we continue, so I would like to invite again some of you who wants to ask question directly. You can raise a hand, just clicking the reaction. Okay. Yes, Shiva Budi.
Okay, thank you, Dr. Bernie, for giving me this opportunity and also for the lecture itself from Professor Susan Sawyers. So basically, the questions that I want to ask is because Indonesia is a developing country with hundreds and tons of problems as well. And one of the problems that is also prominent in this country is a very high number of teen pregnancy, teen marriages, and also diseases of poverty as well. In regards of, of course, as a health advocator, where do you think that we can start as a medical student and also as a doctor in regards of challenging and promoting the health problem that we have right now? Because adolescent health is quite a variety of problems are in here. There's also problems of pediatrics, problems of obstetric and gynecology as well. So it's quite hard to navigate which ones that needs to be focused first. Is it because the low resources as well, especially in the Ministry of Education, and also there's no law that basing this whole problem on. So where do you think that we should start on this problem?
Yeah.
Thank you.
I think it's a really fascinating question, Yasmin, and I think that it's a really important question. On one hand, I think in a country like Indonesia, the risk is you can feel completely overwhelmed by the extent of adolescent health issues that there are. And in that regard, starting anywhere is a reasonable place to start. And so for those of you in academic or clinical leadership roles, anything that you might do is better than nothing. However, one of the reasons that I've been very supportive of, for example, supporting Bernie and Professor Aman Polungun's initiatives within the Indonesian Pediatric Association in relationship to promoting adolescent medicine and adolescent health and an understanding of adolescent health within the Pediatric Association in Indonesia. And one of the reasons that I've been so supportive of the team of leaders who've been involved in establishing Aka Inaha, and there's Diana, I know, is online, and so it's lovely to have you involved, and Francis Handy and Bernie, who have all been involved in establishing this National Association of Adolescent Health, is that I actually think that to have people who themselves are educating themselves as clinical leaders, public health leaders, who can then take on the roles that these folk are doing in terms of influencing your own medical faculties, to be lifting the age of the services that you're running, to be working with your government departments of health, to be challenging them, to be focusing more on adolescents as much as young children. And it's not either or. So just to remind you that in a country like Indonesia, even much more so than in Australia, that triple dividend, you know, if we can delay child marriage and delay parenting into the 20s, then the benefits for the next generation are very, very clear. So if we're really invested in getting the healthiest start to life, then we need to be investing in adolescent health. You know, it's very, very clear. So I think, you know, the honest answer is start anywhere, do something. But I think it is getting critical mass, which is important. And that is why, as I've said, the efforts that I've made in my career to be supporting national associations in Australia, and we sort of reinvigorated our national association, to be supporting the International Association of Adolescent Health, is that in too many countries, there isn't the national leadership. So we have to turn to where the international leadership is. So, you know, as I said, when I trained, there wasn't national leadership in Australia. There were 3 people who had any expertise. And so I had to turn to the States to get further training. Whereas now, you know, 30 years later in Australia, there is a breadth of national experience, but this is a 30-year agenda that we've been sort of sitting over. So I think the development of and the implementation of adolescent health within medical education is really important. Not just pediatrics, but primary care as well, adult medicine as well. That's really important. And really ensuring that in our schools of public health or population health, that adolescent health and development and that public policy stance about what we should be doing is critical. But I would like to return to the challenge of teenage pregnancy, because I think that this is where in countries where there is a very powerful religious framing and a conservatism, that almost there is censoring from doctors because of the religious strength in your community. And this is true in an Islamic dominant country like Indonesia, as it's also true in Latin American countries that have perhaps more a Catholic orientation. So the Philippines, for example, has exactly the same problem as Indonesia, but they are different religions that are involved. One of the really important challenges in Indonesia is how is it that you actually are able to promote access to contraception for sexually active young people, regardless of their marital status, in order that that can be part of the problem. Because clearly engaging young women in particular in education for longer is part of the solution. Actively mandating and being more compliant with the laws that you do now have to prevent marriage under the age of 18 are part of the solution. But contraception and long-acting contraception with, for example, with Implamon and IUDs and things of long-acting reversible contraception is also part of the solution. And this is where none of you as individual doctors are able to stand up and speak to these issues unless you have professional associations behind you and unless you've actually been able to bring on board your government behind you as well. And so this is not easy, but you know, it's really interesting, isn't it? I don't know whether you guys have been following that in India, that has pleasingly now put in place laws that do make abortion legal in India. Then it's not just for married women, but it's recently been taken to the High Court that makes abortion also legal for unmarried women. And it seems to me in India that if you've got a country where abortion is legal, then by definition, you can't have abortion being legal unless contraception is legal as well. So finding a place to be engaging your religious leaders in conversations with you as professional leaders that also engage young people, because this is where there is a generation gap. You know, I think of the 60s as, you know, the era where there was a generation gap, but I think there's no other bigger generation gap in countries like Indonesia and Australia than in the here and now, where your young people, and you only have to ask any Indonesian teacher or any parent of a young person about the sorts of risks that their young people are exposed to. Yet you then have a sort of and I'm going to be crude, a government-dominated religious framework, so not for repeating, a framework whereby it almost is denying young people's reality of the contemporary risks where, you know, I hear in Indonesia about young people being sexually active in hidden spaces in schools. You know, these are ordinary young people who are still at school. This is not a one-off. I have heard this repeatedly from multiple teachers, from multiple health professionals. Now, clearly, I don't think many young people are going to be sharing that with religious leaders in the same page, in the same room, or indeed with government policy folk. But we have to find ways of bringing young voices to these conversations, because I really feel that those voices are going to be far more powerful than the voices of, you know, someone like you and me here. So I think really listening to young people and finding ways of young people being part of the solution here is really critical.
Okay, thank you, Professor Sawyer. It is still, like you said, it's not an easy problem, yeah, and then very challenging even in our country. So your input is really important for us. Okay, now we go on again. So because we still have about less than 20 minutes to go. So is there anybody else? Okay, Natasha, yeah, you may ask.
Thank you, Dr. Bernie, for the opportunity, and also thank you for the eye-opening lecture, Prof. Susan Sawyer. So my question is, from the lecture that we have heard, there are quite a lot of improvements that we should do for adolescents' health. However, is there any way for us to be more approachable for these adolescents, as there might be some barriers from them themselves doesn't want to come to us, or their family would not like us to reach them out? Maybe there will be some inputs or how we could actually be more approachable to this age group, especially in Indonesia. Thank you.
Yeah, thanks, Natasha. You know, as I said in the lecture, I think part of that approachability comes from how we ourselves engage with young people. And so that is learning a particular respectful style of engagement with young people and with their parents. So parents are very threatened in Australia. Australian parents are very threatened if we suggest that we want to see young people by themselves. And they immediately think that we want to talk about all of these really sensitive things that they don't want us to talk about with their kids. But learning, you know, I've learned over the years that if I say a parent of a young person who's got a chronic health condition, for example, and let's just say it's a 14-year-old, and my guide is that by the age of 14, if I haven't started seeing a young person by themselves for part of the consultation at the age of 14, I need to start doing so. And so typically what I would say to the parent is, I see that little Natasha has just turned 14. When Natasha's 18, she will be transferred to an adult service. Let's just say that little Natasha's got chronic inflammatory bowel disease or has got chronic renal disease, and Natasha will graduate from our paediatric hospital and will need to see the doctors at the adult service. At the adult service, they are not going to be interested to talking to you as her parents. They have an expectation that Natasha is mature enough and capable enough to actually speak for herself. And so what I then say, I then align myself with the parent. And so I then say to the parent, so between you and me, Mrs. Yamina or Mr. Yamina, between you and me, over the next 4 years, we've got a really important task to do between the two of us. So I share this, I align myself with parents as putting myself on their side. It's our responsibility over the next 4 years to really help equip Natasha with the sort of skills so that when she does get transferred to the adult service, she is fully able to have conversations with health professionals that I imagine she would be terrified to have by herself now. She will be able to negotiate the complexity of the health system that I'm imagining, is not able to do at the age of 14, but that over the next 4 years, that's a task that we have. I tell you what, Mrs. Yamina, in my experience, the best way that I've learned to do this is that for part of each consultation, spending a little time with Natasha by herself and me asking questions of Natasha by herself without you supplying the answers is one of the best ways that I've found for Natasha to, really get a sense of that adult responsibility. So if it's all right with you, the next time I consult with you, I'd like to see Natasha by herself to start with. And then I'd like to very much then engage, you and your husband in the second half of the consultation, because obviously you're really, really critical to what happens at home. So that's the sort of conversation that I have. Does that make sense? So it's not saying to the parent, you don't matter anymore. But I think in a country like Australia, when I have those conversations with the majority of parents, they have an understanding of this. They sort of do have an understanding of adolescent development. And I have become aware from research that colleagues have been doing, particularly Dr. Francisca Hundy, who's doing a PhD at UE. And she's been undertaking, as part of that work, a range of interviews with parents of adolescents. And what's very apparent is, and this is very much around non-communicable disease risks, about what expectations parents have about food choices and physical activity and screen time with their kids. And what's very apparent is that Indonesian parents view their roles and responsibilities quite differently and really don't seem to have an understanding of what young people are really needing from their parents. And I think they think it's just going to sort of happen automatically. And I'm not wanting to be critical of Indonesian parents at all, but rather to be signalling that I think it's been a failure of the professional and sort of government folk consistent with, in a sense, how recent this thinking is of adolescent health in low and middle income countries, whereby there's a failure of books on parenting, for example, that are inclusive of the adolescent years. And so you can go to any bookshop in Australia and you can buy, lots and lots of books on toddler taming and books on, breastfeeding and the first couple of years of life. But you can also buy lots of books on adolescent parenting and how to be a good parent of teenagers. But I am aware that in Indonesia, this area of parenting is in its infancy, if you like. And so needing to be thinking about how do we direct parents, how do we equip parents, how do we run parenting groups for those who might be interested. And this is probably best done through school communities. But really developing up that NGO network that's really working to be building that understanding everywhere within the Indonesian community. Bernie, I don't know whether, or Diana, whether you might have any other comments to make in relationship to this, because I know that, it's sort of a challenge of something that I know both of you have been grappling with as well. But did either of you have any reflections on this?
Yeah, I think it's not easy to be a parent. I agree with you, especially if you have adolescents, because we do. Professor Sawyer and I have adolescent here, and I agree with you. Probably in Indonesia we don't have much books available, yeah, because there is no school for parenting. What we can do is we read and probably learn from others, yeah, how to become a parent. But this is, I think, what Natasha asks is very critical, I think, yeah. So we need to be able to educate our patients later on, yeah, and also how, like Professor Sawyer mentioned to you, how we deal with the adolescents. That's why we have our elective module, Professor Sawyer. So we want to teach them how to deal with adolescents, how to deal with the parents too. And actually, I'm so happy because I would like to say also that when I was in Adolescent Task Force, we finally published our first recommendations how to do the psychosocial interaction with the adolescent. That's already published in Indonesian Pediatric Society, IDAI. And our second book is the compilation of adolescent health, which also you wrote one section. I think you wrote one article, Professor Sawyer, that is for us, for the medical students, for health professionals, probably if you want to learn something more about adolescents, in also in Indonesian perspective a little bit, because it's also quite specific in adolescent health in Indonesia too. So probably you can read that. So that's my additional comment.
I'm putting in the chat. Check out
Okay.
Australia's, it's called the Raising
So
Children Network.
do you have
In the chat, I just suggested you check out the Raising Children Network. If you go on that online, it started off as or it's a website for, was it the Raising Children website? I can't think. Raising Children Network, I think is what it's called. But it's a website that started off it's a parenting website, or is it the, shivers. Let me have a look. Maybe it's the parenting children, raising children. But it's, you'll come across it because it's a very big website. But it started off as a parenting website that focused on 0 to 8-year-old children. And then due to efforts of people like me, it was then lifted up to the age of 12 and then the age of 15. And now I think it extends up to 18. And that's the sort of network that I know that some people in Indonesia had had some discussions with the Raising Children Network team about whether this could be translated into Indonesian, for example, in Bahasa, because a resource like this isn't available in Indonesia. And then they quietly realized that it was a really big task and there wasn't the funding available for it. But, promulgating these sorts of resources, getting your government to be investing in these sorts of resources. Yeah, thank you. Raising Children. Thank you. Is, I think, has been a mechanism in Australia of publicising and bringing easy access to people, not just in Australia, but who speak English across the world. So the opportunities is, how do we, bring these resources like this and make them available to parents of not just children, but parents of adolescents in Indonesia as well, who don't speak English and for whom, the context of Australia is far less relevant. So these are the sorts of things where leadership from professional associations working with government are really, really important in terms of starting to drive some of these investments in the preventative space.
okay, Professor, sorry, I'm back. We have problem with technical problems. Thank you. But before we continue with our students, as probably you acknowledge here, there are some other professors here, so from Indonesia. So I think I would like to open some questions for staff members or professors here, if they have some questions. If not, we go back to our students. Okay, if not, so probably the last questions then. Yeah, Jonas.
Thank you so much, Dr. Burney, for the opportunity. Good morning, Professor Sawyer. Allow me to introduce myself. My name is Jonas. Thank you so much for your informative presentation. I would like to ask about two diseases from the slide of the disease burden regarding about sexual and reproductive health and mental health. You mentioned that during adolescence age is arguably one of the most influential times during one's life. And in this day and age, it is clear that gender and sexuality has become more complex. I would like to ask on how to educate perhaps the LGBT in terms of like a healthy sexual relation, and when the topic itself can be considered taboo in Indonesia, and laws are restrictive towards stuff like that. And another thing I'm also curious is how can we maintain a healthy mental health for them, as it may be difficult for them to discuss and be open about it, about their sexuality, especially when it is heavily looked down upon in Indonesia, considering that Indonesia is a religious country and may not be easy to apply such educative programs for certain people. Thank you.
Thanks very much for asking the question, because I think this is such an important question in terms of sexual minorities, where we know that even in a country like in Australia, where sexual minorities, whether it's LGBTI or increasingly the recognition of transgender, is much more on the policy landscape, and certainly in terms of gay and lesbian young people, absolutely acknowledged within schools very, very openly in a way that it certainly wasn't when I was at school. But even so, in a country like Australia, we know that young people who are of a sexual minority background have much greater internalized stigma and shame, and have a much higher rate of depression and anxiety. So it's about a threefold rate. So just stepping back a bit to be making the link with mental health, we know that the incidence of mental disorder increases very dramatically over the adolescent years, coincident with the timing of onset with puberty. So mental health is very much, and when we say common mental disorder, that's depression and anxiety in particular. So I think you're absolutely right to be calling out the significance of LGBTIQ+ young people as a particular population to be needing to think about, and to think about how we do that. Now, one of the things that I always remind my colleagues in Indonesia is that you are doctors first and foremost. You are practicing in Indonesia, and you are practicing therefore within a particular cultural framework, but you are first and foremost doctors or medical students in training. And therefore, I think it's really important that you are aware of your ethical frameworks with which you are working. So in Australia, for example, if I personally was not able to support the notion of contraception or abortion for young people, which I do support, as you probably are aware, but if my personal belief was that, and that counteracted with my religious beliefs, and I did not feel I was able to prescribe contraception for unmarried teenagers, my legal obligation in Australia is not to say that to a young person, not to judge or shame them, but find a way of very respectfully saying, Jonas, I tell you what, in terms of this particular challenge, this is really important. And what I would like to suggest is that you see my colleague, Dr. Burney, and Bernie is really expert in this particular area, and she will be able to prescribe contraception for you. So I'm not making the person feel doubly stigmatized. I'm promoting access. Now, that's what I am legally obliged to do in Australia. But under my ethical practice, my code of conduct, if you like, as a doctor, to me, that is equally or even more so what I should be doing ethically if I felt unable to do that myself. And I think it's this challenge about how do you weigh up and balance your role if you are an Islamic observer and are wanting to follow the tenets of your religion, how do you balance that with your roles and responsibilities as a doctor, and to recognise that these are distinct roles and responsibilities? Now, I came across a fabulous poster years ago that I always used to give in talks, and I give a talk, actually, and I must remember it, Bernie, remind me, I give a talk every year. When I was in Indonesia a couple of years ago, it was actually, it was at the launch of your new research institute, and there were a lot of questions that some young women were asking about sexual health, and I was very disappointed that the clinical leaders on the podium basically refused to engage in the seriousness of these questions. It turned out that the two young women who were asking the questions were staying in the same hotel that I was staying with, and they then jumped on me and asked me all of these questions about contraception, and they had all of these myths that they didn't know anything about contraception. And so I spent the next hour with a free consultation on sexual and reproductive health with these two young people. But on the basis of that, I give a lecture every year to the students from UI who come to the University of Melbourne as part of their Bachelor of Medical Science on comprehensive sexuality education, and talk about a whole lot of approaches. And within that, I have a slide that has just a slide of just patients sitting in a waiting room from neck to knees. And what the caption says is, you don't have to tell us you're gay if you don't want to, but you can. And that as a poster was one of the most powerful things that, in a sense, was recognising quietly that sexual diversity exists and that we are a safe service in which you could ask us questions, and that you might expect to be questioned about your sexuality as well, rather than assumptions being made. So I think firstly, in terms of our ability to be able to talk about sexuality and to acknowledge the diversity of sexuality, most of us as medical students and young doctors need to do a lot of work ourselves to feel comfortable to be able to talk about this stuff without blushing, as I certainly always did when I was at your age. I couldn't talk about any of this stuff when I was a medical student. I couldn't talk about any of this stuff when I was doing my higher degree in my late 20s, doing pubertal assessments on males and females with cystic fibrosis. You know, I was so, felt so, you know, untrained with any of this. So I think basically it's about training ourselves, doing lots of reading, doing lots of talking, and doing lots of engaging with our patients as well, because it really is about learning by doing. So this is where I would be asking you to be having, you know, sitting down with a group of young people, school-age young people, and asking, so tell me, you know, what's the situation in terms of sexual minority status at your school? Does anyone acknowledge this? What's the issue of stigma? Is there bullying that goes on? What would help? What could I do as a medical student? So, you know, some simple questions can actually go a long way. But I would also encourage you, and Diana had promoted this in the chat, to think about engaging with the International Association of Adolescent Health's Young Professional Network, because they regularly have webinars, and this is the sort of thing where as medical students you can ask for some topics for webinars, and that this is a way by which you might actually learn from other countries about what they might be doing as well.
Thank you so much, Professor.
Thank you. Yeah, thank you, Professor Sawyer. Actually, I think we have two more questions. Is it okay for you? Is it okay
Sure.
if two more questions? Okay. So I think Ade Gautama. Yeah.
Okay, thank you, Dr. Bernie, for the opportunity. Thank you for the eye-opening lecture, Prof. Susan Sawyer. So my question is regarding the adolescent health and chronic illnesses in adolescent health. So as we all know, that adolescent health is a complex concept, and there are a lot of factors related to adolescent health. For adolescents with chronic illnesses, are there any role of social factors and media in determining the outcomes of their health regarding their chronic disease? And how should we use these related factors to improve their health too, if it's possible? Thank you.
Good question. Certainly there are a lot of social factors. So if we think about the social determinants of health, regardless of what disease outcome we're measuring, whether it's asthma, whether it's chronic inflammatory bowel disease, whether it's cancer, the health outcomes are worse in socioeconomically deprived young people. So social status matters. And that's not simply in terms of being able to access higher quality health services if your family is from a wealthier background, but presumably it's in terms of having greater health literacy, greater power to follow through, greater autonomy, greater sort of sense of being able to do what you are being asked to do, and greater understanding in terms of why you might do it. So I think that at the very least, you know, those social, the socioeconomic status is critical. The other thing, and I really didn't speak about this much in giving the examples of chronic illness, but I think you are absolutely right in recognizing that for young people with chronic health conditions, that it is peer relationships which are incredibly powerful. And many young people with more severe and complex chronic health issues feel very socially excluded. They feel themselves stigmatized, even if they're not excluded themselves. They just feel different. And they are different because, as I said with some of those slides, they have to do things that other people their own age don't have to do. So I think there are ways in which we need to be highlighting with young people that they're not the only one who has this experience. And this is where I think patient support groups, adolescent support groups, can be incredibly valuable. At the Children's Hospital in Melbourne, for example, we've long run a group called CHIPS, the Chronic Illness Peer Support Group is what it stands for. And this is a peer support group for young people with different sorts of chronic diseases. We have NGOs, so the Diabetes Association runs peer support groups and camps for young people with diabetes. There are camps for young people with chronic renal disease. These are really fabulous to have because they're ways where young people can get together and really feel at home, recognizing that it's not just them. But you don't just have to get together with young people with the same chronic conditions. And indeed, the CHIPS groups that we run are young people coming together with different sorts of chronic diseases. And I think that there are some many benefits that come from getting people together with a generic peer support group. But it is incredibly powerful because typically young people do have their education interrupted because of the amount of time they have to spend coming and seeing health appointments, often because of the physical differences, whether it's stunting with chronic renal disease, whether it's body scars. Even in the absence of visible conditions, they still intrinsically feel different, which is one of the reasons why the data suggests that young people with chronic health conditions have a higher risk, not just of mental disorder, of depression and anxiety, but also have a higher risk of substance use and of acting out behaviour, which is probably, I would argue, a bit like that same slide that we went back, Larry Steinberg and the experiment with the racetrack about young people wanting to fit in front of their peers, because if you've got a chronic illness and feel that you don't fit in because of the inherent nature of your chronic illness, you might feel you have to try harder to be one of the gang. And if one of the gang is that it's sex, drugs and rock and roll or whatever it might be, then that's what you might feel more obliged to participate in. So it places you at a double risk, if you like. Does that make sense? So I think establishing some peer support groups, running annual camps, this is where the value of health professionals engaging with NGOs in the community to know what's available is incredibly important. Just running an annual education day for, again, if it's say chronic inflammatory bowel disease or chronic renal disease, to run a half-day education session where parents and young people of teenagers might come together across a day, but within that day you might have some breakout groups where it's just young people meeting with young people, is one of the ways that you can do those sorts of things as well.
Okay, thank you, Professor Sawyer. I just want to add that in their module, there will be rotation also. And we also include some staff from chronic illnesses division, just like nephrology, and then allergy, immunology, hematology, and they have some, what Professor Sawyer mentioned, they have some support groups for the chronic diseases patients, and so you can have time to engage with them in this module. Okay, thank you, Prof. Sawyer, for mentioning it. Okay, I think one last question from Vincent. Yeah. Okay.
Okay, thank you, Dr. Bernie, for the opportunity, and thank you, Professor Sawyer, for the lecture, for the wonderful lecture. So it is interesting for me to see that the birth rate actually decrease following the increase in educational level. So I just want to ask, what are our roles as doctor or healthcare workers in maybe educational sector and justice sector, as you mentioned, which influence the adolescent health in healthcare, especially in Indonesia?
Really good question. I've been involved over the last few years in working with WHO and UNESCO. So UNESCO is the UN agency responsible for education in schools. And we've been working with them to be developing some new global standards for what's called health promoting schools. And as so health promoting schools is an idea of where schools have got a responsibility for promoting the health and well-being of students, not just their educational outcomes. And within that, one of the standards, so there are 8 standards, and one of those standards is about health services in schools. And so I think that one of the opportunities that we have as doctors is working with our communities in which we live, our geographic communities, and forming relationships with school principals and school communities, and supporting them to be, for us, for those of us who are interested in adolescent health, to be a resource for the schools within our communities to bring to their attention the sort of things that they could be thinking about doing. And so in many low and middle income settings where there are more traditional roles and perceptions about the roles of schools are primarily around achieving the best academic results. Increasingly, what health promoting schools is about is trying to say that the responsibility of schools is not just around promoting the best academic outcomes, but actually it's the same sort of thing about adolescent health and development. You know, it's the importance of schools helping equip students with the assets and capabilities to be successfully making their transition into adult life. And academic success is only one piece of that. So in that sense, it's seeing our role as health professionals as a resource. We are obviously, if we are working in clinical practice, we're a resource for our individual patients. But many of us move into more public health roles or move into research because we feel we want to have a wider influence beyond the individual patients that we might consult with. Now, and so that's where working with government, Bernie before mentioned this Adolescent Health Task Force that she had been involved in leading, which is a task force both within the Indonesia Pediatric Society, but then also a task force within the government as well. So the opportunity of doctors being a resource for government and being a bit of a mosquito, not being a yes man, as I would say, but being a bit of an annoying resource, pushing government, because government doesn't want to do most things. Certainly government in Australia doesn't. And you have to push government to get them to sort of understand how they could think about doing things differently. So I think part of our roles when we mature as medical students is learning that there's a diverse, or part of the role is understanding the diversity of the roles that we can embody within our careers and at different times within our careers as well, not all at one time, obviously. And being a resource for our communities and being a resource for our governments, being a resource for our religious leaders who try and quietly, subtly expand their understanding, for example, about mental health in young people, about sexual health in young people. These are some of the things that are, if we are religiously inclined ourselves, we have an entree and an opportunity to do in a way that if you're not religiously inclined, you probably don't have that opportunity to do. Does that make sense, Vincent? Sort of it's a roundabout way of answering your question, but I think it's really engaging with schools and getting our professional associations to be engaging with schools as well. But I really would commend to you the new global standards for health promoting schools, which is available on the WHO website. It's a bit hard to find. I might create a link. I might send Bernie a link so she can share it with you guys in due course. And then just finally, I might say twice a year or so, we run a MOOC, a massive open online course on global adolescent health. We finalized this in 2015, so it's now relatively old, but in asking a few recent graduates who have undertaken the MOOC, and I think it's nearly towards the end, so it just started in early September, runs for about 6 weeks of content. So you could probably pop on it now, but I probably wouldn't recommend it at the moment. Although actually, for those of you who are doing your elective, maybe you might learn something. But so if you search on Coursera and global adolescent health, or just search on global adolescent health and education, you'll come across this massive open online course, which is free. And in that, we talk a little bit about schools, but this was prior to the health promoting schools framework, so there's nothing specifically on it in that. But I really think that post-COVID, this interface of schools and health, particularly in the context of mental health and well-being and sexual health and well-being, has really risen to the surface. And I think it's a really important opportunity for health professionals. How do we engage differently with schools?
Okay. Okay, thank you so much, Professor Sawyer, for a wonderful, very comprehensive lecture and discussions. I think we learned a lot from you. And really, this is a very good beginning, I think, yeah, because you really motivate. I think you really motivate. I think my students are really motivated right now for about learning more about adolescent health, which is sort of neglected before. Yeah. So in the next 4 weeks right now, so they will learn a lot, not only in clinical in hospital, but also in community. And like you said before, it will be, we collaborate with other multidisciplines like psychiatry, OBGYN, and then dermatovenerology, and also even in our pediatric department, we also involve like almost all divisions that is related to adolescent health, in chronic diseases also, and also in endocrinology and nutrition, and also in growth development. So I hope this can, and not only motivate, but later on, they will become our future, yeah, Dr. Prof. Sawyer, like you mentioned before. Okay, I think we come up to our end of guest lecture, and Professor Sawyer also wrote something in the MOOC, Global Adolescent Health.
Yeah, if you do a search on that, you'll come across the MOOC.
Yeah.
All
yeah.
right.
But
I wish you all
that,
well for your studies, and I shall.
Can we take picture for a while?
Yeah, yeah.
Okay. Just before that, so who will help me? Yeah. Okay, ya. Okay. Could you open the dibuka ininya, siapa yang mau membuka kamera? Could you open the camera? Ya, kita foto bersama ya. Oke. Bagus ini. Ini bagus.
slide kedua.
Slide kedua.
1, 2, 3. Kemudian yang terakhir, slide ketiga.
Slide ketiga.
1, 2, 3.
Okay, thank you so much again, Professor Sawyer, for your wonderful lecture.
Good luck
I
to you
hope
all.
best
Look forward to hearing what you learn.
Okay, thank you.
Thank you, Professor.
Ya, saya tutup untuk acara hari ini. Terima kasih Profesor yang sudah hadir. Ada Dr. Safira juga sudah hadir kembali. Kemudian Prof. Niko, tadi juga saya lihat ada Dr. Widianita dari Palembang, ya, ada Prof. Kusnandi juga dari Unpad tadi sudah ikut dalam acara ini. Baik, saya tutup untuk acara hari ini. Ini adalah bagian dari modul elektif kesehatan remaja. Mudah-mudahan ke depan nanti tahun-tahun berikutnya ada lagi yang ingin bergabung pada modul elektif kesehatan remaja dari Departemen Ilmu Kesehatan Anak FKUI RSCM. Baik, terima kasih semuanya. Terima kasih Dr. Ira, Prof. Miko, semuanya, Dr. Dina yang sudah banyak sekali membantu. Saya tutup. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Waalaikumsalam.
Terima kasih banyak, Dok.
Waalaikumsalam.
Sama-sama.